The goal of the 19th is really to change the conversation around how we talk about women and LGBTQ people in politics.
We are firm believers that all issues are women's issues. Our readers are people who want to be better informed and better able to participate in democracy.
We're aiming to change the future of American journalism by giving women and the LGBTQ community the platform and the voice that they deserve.
There's never been a better moment than right now.
The 19th is the newsroom that we've been waiting for.
Hi everyone, and welcome to Live with the 19th. I'm Amanda Zamora, co-founder and publisher of The 19th, an independent nonprofit newsroom that aims to empower you with the information, resources, and community you need to be equal participants in our democracy. The past 2 years have damaged the mental health of millions of Americans. Data shows that women, LGBTQ+ people, and people of color are especially feeling this impact, with more and more people reporting symptoms of anxiety and depression. And although the mental health care system has become overwhelmed, professional mental health resources still are not accessible to many who need them. For Mental Health Awareness Month, we're partnering with State of Mind, a project of Slate magazine and Arizona State University, for a critical conversation about the mental health crisis in this country. Today, you'll hear from practitioners about how we can best prioritize our mental health. A senator will discuss bipartisan legislation seeking to address the crisis, and we'll talk about grief, something so many of us are working through after 2 years of tragedy and loss. Before we get started, we'd like to thank our founding sponsor, Pharma, for making this event possible. Here to share a few words is Ann McDonald-Pritchett, Senior Vice President of Policy and Research at Pharma.
Thank you, Amanda. Good afternoon. My name is Ann Pritchett, and I'm the Senior Vice President for Policy and Research at Pharma. First, I want to thank the 19th team for the invitation to join this conversation on an issue that's vital to all of us, mental health. In my role at Pharma, I've seen the devastating toll of the pandemic, but also witnessed incredible advancements that the biopharmaceutical industry has made to combat COVID-19 with new vaccines and treatments. The impacts of this pandemic have been far-reaching, exacerbating mental health issues, but also bringing attention to long-standing gaps in access to mental health care and a renewed focus on the need to address the stigma surrounding mental health. Since the beginning of COVID-19, rates of anxiety, depression, and suicidal ideation have increased for people of all races and ethnicities. Nearly 1 in 5 adults are living with a mental illness that impacts their daily lives. And 1 in 5 bereaved caregivers experience depression and/or complicated grief affecting their own health and quality of life. I have felt these impacts in my own life, having lost both my father and my father-in-law during the pandemic. As one of the primary caregivers for my father, I can tell you that I continue to carry the grief and other impacts with me every day. But I'm also here to tell you that acknowledging you aren't okay is a critical first step in seeking help for your mental health care needs. Sadly, though, mental health is perhaps the most neglected of all health conditions, with many people still not receiving a timely diagnosis or the treatment and care that they need and deserve. The good news is that the biopharmaceutical industry continues to make significant advances in science, which is leading to an entire new era in the treatment of mental health illness. There are 138 medicines in development by biopharmaceutical research companies showing real promise to help the millions of Americans suffering from some type of mental illness. And while there is promising research taking place, our work is far from done. A recent poll showed that 1 in 3 insured Americans with mental health conditions report that their out-of-pocket costs are more than they can afford. We must collectively advocate for patient-centered solutions to, number 1, combat the stigma associated with mental health, address disparities in access and affordability related to mental health care screenings, treatment, and other supportive care, ensure that patients are treated holistically with a focus on both physical and mental health, seek to better understand the long-term impacts of COVID-19 on the brain, given that so many COVID patients are experiencing increased mental health issues. And most importantly, we need to continue engaging in conversations like this to address the mental health needs of all communities. And with that, I would now like to turn it back over to you, Amanda.
A quick reminder that while sponsors help keep the 19th events free for our readers and viewers to attend, they play no part in the programming of these conversations. As today's conversation kicks off, We hope you'll share what resonates with you on social media using the hashtag the19thlive. And if you have not yet subscribed to our free newsletter, please be sure to do that at 19thnews.org/subscribe, where you can find out about upcoming 19th events, read our incredible journalism, and more. Now, let's get started. Joining us for today's discussion, we have Dr. Joy Harden Bradford, a licensed psychologist and host of the Therapy for Black Girls podcast. Dr. Bradford's work focuses on making mental health issues more accessible for Black women and using pop culture to illustrate psychological concepts. We also have Dr. Kristen Ekstrand, a board-certified child and adolescent psychiatrist and an assistant professor of psychiatry at the University of Pittsburgh. Dr. Ekstrand has published 4 books and several peer-reviewed papers on the health needs of LGBTQ+ communities. Jayo Miko Makasakit, the 19th's Chief People Officer, will moderate this conversation. Jayo?
Thank you so much, Amanda, and thank you so much, Dr. Joy and Dr. Kristen, for joining me in this conversation. I am not one to be easily starstruck by celebrities, but for folks that work in mental health, this is as close as I can get. This is an issue and subject matter near and dear to me, and I'm so glad to be talking to both of you today. But to start off with an easy one, for some folks who may not be familiar with therapy and mental health services in general, Dr. Joy, if you could start us off, what exactly is therapy and how might someone benefit from it?
Ooh, such a great question, but a big question, Jayo, right? So I think therapy can look a lot of different ways, and so I think that that's important. But generally, what we're talking about is a relationship with a trained mental health professional, where you are spending time talking through concerns, developing insight, and really where you can have an authentic and genuine connection with a person, unlike the ones you may have in other places in your life. So one of the things that I think is most powerful and impactful about therapy is that it really gives you the space to practice kind of being human, right? And what it looks like to be honest and have difficult conversations and share things that may be shameful in other places of your lives. And so I think therapy can be helpful for a lot of different kinds of concerns. And I think one of the most common misconceptions is that you have to wait until you're in a crisis to go to therapy, when truly therapy can be helpful to prevent a crisis, but also for lots of different concerns. And so there are ways that you can learn different coping strategies in therapy. Again, you can just practice on being human and having genuine connections with other people. And it can also be helpful to reduce any symptoms that you're finding difficult that may be impacting your functioning in your life.
Wonderful. As someone who is the product of great therapy throughout my life, I can definitely attest to the benefits of it. But I don't think I always had a good relationship with it. I think I didn't always know what it was about. Dr. Kristen, from the folks that you serve in your work, why do you think more people aren't seeking therapy?
Yeah, I think this builds a lot on what Dr. Joy said. There were a couple of words that she used that I think really articulate why therapy is hard to do, right? It is supposed to be a space that is safe. It is supposed to be a space that is safe to be vulnerable and to share things that bring out feelings within us that we are working through, like shame, like doubt, like guilt, that can be really challenging. And that when you're trying to share those things with another person, that you're trying to really have a therapeutic, healthy human relationship with, that has to be built on trust. And so, the therapeutic environment itself, the space that it occurs in, has to be one that feels safe and has to be one where trust can grow. And one of the scariest things I think about therapy is that, especially for communities that have been judged in the past, they're judged for who they are as people. So a lot of the communities that I work with are part of the a lesbian, gay, bisexual, transgender, queer, LGBTQ umbrella. Some of the reasons that people end up coming into therapy in the first place is to deal with a lot of feelings of guilt and shame and self-worth. I'm not good enough. people don't like me. They don't like me for who I am. And so the very barrier of sort of trying to talk about those things with someone without judgment, when you know that people judge you for who you are, can be very, very scary. And that can be really compounded for people as well, because a lot of folks do come in, maybe trying to go to therapy a second time or a third time and give it another shot, because the first time they did feel judged. They were judged. They weren't, given care that was inclusive of their identity, affirming of their identity. And so there can be kind of a dual hurdle there, because it's not just about dealing with your own, tough feelings about yourself and, those types of difficult topics that we need to talk about. Therapy needs to be built on safety, and it needs to be built on trust, and it needs to be built on non-judgment. And anytime that creeps into the therapeutic environment, it's a very scary thing, and it pushes people away. And the reason why that happens is always very complicated, but it can happen because the therapist may not have received training in working with folks in diverse communities. And that's really, really important to know about. So it's built on safety, it's built on trust. If that isn't there, if you feel judged, if you feel like someone doesn't respect you for who you are, people aren't going to come back. And we see that time after time after time, where what therapy is supposed to be is not what is provided in this space, because it's not inclusive, it's not affirming. So I think that's a big reason why a lot of people avoid it, not just because of shame and guilt, but because of the therapeutic environment not being what they need.
Yeah, I certainly resonate with that experience, especially with not being able to find the right fit sometimes with therapists or mental health providers that don't create that safe environment. Dr. Joy, a huge part of why you started your podcast, Therapy for Black Girls, was specifically to bring not only relevance but accessibility for Black women in particular. And hand in hand with that is the fact that they do need the help to navigate these systems. These systems weren't created for them. So could you talk a little bit about those barriers that Black women in particular face with regards to therapy and mental health services?
Yeah, I mean, Dr. Kristen has already laid out some concerns really beautifully, so I think it's also important for us to keep in mind that like the entire field of psychology was started by like straight white men, right? And so when you think about this being the place that is called for healing, that doesn't always look comfortable and affirming to people who do not look like straight white men. And so a lot of the work that I do at Therapy for Black Girl is really creating spaces for people to come and have the kinds of conversations that are important to them. And it is really important, like Dr. Kristen mentioned, therapy is supposed to be a safe space, but if the therapist has not done their own work in terms of taking care of any biases they have, or really checking their own privilege and being able to have some tough conversations, then it can become a more punitive place. It can become an even more harmful place when you already came to therapy because you were feeling harmed maybe in some way in the first place. And so Therapy for Black Girls really is about having the kinds of conversations that Black women want to be having, because not everybody will go to therapy. So we haven't talked about this, though I'm sure we will, but cost is also incredibly prohibitive in terms of being a barrier for therapy. And so even if everybody could afford it, there are not enough therapists also to go around. So, there are fewer than 4% of psychologists who practice that are Black or African American. And so if people wanted a therapist who looked like them, or, they felt like shared something culturally in common with them, there would not be enough to go around. And so a large part of what we do on the podcast is to try to give people something in case they can't ever go to therapy, or to give them a seed that may grow once they do eventually go to therapy. It's also in the Black community, there's such a stigma related to therapy. So many of us have not come from families where therapy was okay, or where family members ever went to therapy. And so the idea that you're going to go and talk to a stranger about some very personal, secret kinds of things in a lot of ways goes against a lot of what we have been taught culturally. I know in my own home, my family had this saying of whatever goes on in this house stays in this house, right? And so when you think about that, that is where some of that shame and guilt that Dr. Kristen talked about can really start to fester. And so the idea of talking with a stranger about some very personal things feels really difficult. And so when people are taking that first step, a lot of times what helps them feel a little more comfortable is to find a therapist who they feel like will get them, right? Like there will be some things that I probably won't have to explain to this therapist because, you know, they look like me or they have a similar cultural background. And so I think that that is one of the largest barriers for reaching out to therapy, especially for Black women.
So a follow-up then, Dr. Joy, it's something you addressed and something I heard in your podcast, that percentage of licensed therapists that are Black women being only 4%, and the population of Black women being higher than that. How do you address sort of the desire for folks to seek a therapist or mental health provider that looks like them, that comes from a similar background? Obviously, it helps with the safety that we were talking about earlier. But how do you advise folks who would want that? But obviously, it's not a possibility within our current system.
Yeah, so I do think that that is very much a systemic kind of a conversation, right? So one of the issues is, you know, just more people coming into the field, but we also have to take some steps back and think about how many steps are required before somebody even becomes licensed, right? So again, cost is prohibitive in a lot of these things. So you're looking at 4 years of an undergraduate degree, at least probably 2 years of a master's degree. And then if you wanted to go on for a doctorate or some other kind of advanced training, you're looking at another 3 to 4 years. A lot of times that does not come with scholarships or assistantships. And so what you're looking at is people taking out loans to do this kind of work, right? And so just the process of becoming a licensed therapist, I think, can be prohibitive for a lot of people, which is why it may be difficult for a lot of people who come from marginalized communities to get into the field. The other thing is that graduate programs are not always very affirming and welcoming, right? And so if I'm going to be spending all of this money, I definitely don't want to be spending money to be a place where I'm going to be harassed and have racial harassment and all kinds of other things. And so again, those spaces not feeling welcoming and not being places where people who come from traditionally marginalized groups are welcomed and affirmed, I think it's also a reason why then on the other end, consumers cannot then find the therapist that they are looking for. But one of the ways that I'm really excited about being able to provide more services to people who are looking to work with Black women therapists is through group therapy. And so group therapy, I think, is a modality that is often kind of overlooked because when people think of therapy, they only think one-on-one therapy. But I think that there are some incredibly powerful experiences that you can have in group therapy that one allow to kind of scale. So you can have 1 or 2 therapists with, 10 to 12 different clients, and then you can see more people, but also you can learn from the other people in the group. So I don't think, yes, your therapist is trained in some things, but there's also a lot of wisdom and knowledge that can come from talking with peers and interacting with peers as well.
Thank you. Dr. Kristen, you tackle the scarcity issue in a different way in your work. Part of your work revolves around training mental health providers, whether or not they're from those backgrounds, to be more affirming and to be more informed in their practices, in particularly working with LGBTQ plus folks. What's that work like?
Yeah, no, that's a great question. I think it's helpful. I think Dr. Joy alluded to this idea that if you work with someone who looks like you or shares the same identity as you, that there is going to be, I think that there's this sort of like assumption that they're going to get you. And I think there's parts of that are absolutely 100% true. There's a shared struggle that a lot of folks coming from marginalized backgrounds go through. And then there's also things about each of our journeys that are unique, that are intrinsic to our narrative, that we can only help other people learn by finding the words to share about ourselves. And so this is something that's really built into more affirming styles of therapy is the power of the narrative, or narrative medicine or narrative therapy. So I think that when we think about why that narrative is so important, why someone's story is so important. There are sort of two facets of it that emerge when we think about training healthcare professionals, mental health professionals when they come in to the healthcare system. I think two different paths to that. One we refer to, I think, is sort of general affirming care, interpersonal skills. A lot of this sort of relies on this theory of cultural competence, which is that there are certain things that you can learn how to do and do them well that will create a space that is affirming. And it's really about creating that safe space. And so when we think about LGBTQ individuals, these are things around, being able to use someone's name, being able to use someone's pronouns, being able to understand that relationships are complex, identity development is complex, that trauma is an intrinsic part of something that most people in LGBTQ communities go through. So being able to establish safety, establish how someone wants to communicate about themselves, and knowing that the story is really important, I think are sort of the foundations of how do you create a space that someone can sit down in a room with you and start to talk. Where you go from there, I think, is a different journey, right? And this is one that we oftentimes talk about as being, cultural humility, or clinical. I think humility is a better phrase that we don't use as much. But this is where there are certain skill sets, I think, that tend to be used, that tend to work well when you're working with diverse communities. And there's clinical training that goes along with that. And as Dr. Joy alluded to, there aren't a lot of spaces to do it. So in traditional training institutions where you get your degrees, a lot of these spaces where you do your training don't have an identity specific focus of care. You work in a clinic or set of clinics where people come in, and that's where you learn to do your training. You're supervised by someone who most likely does not look like you and most likely does not look like the patients that you're working with. And so it's really hard to sort of develop a skill set around how do I work with a specific diverse population. And so, learning how to work with and do therapy with folks of diverse backgrounds, including like LGBTQ communities, building those clinical skills to be able to do that, I think is a specific challenge that as far as tools to do that go, they're still growing. So a lot of people use online training mechanisms, a lot of community-led clinics. This is really, I think, a fantastic place to do that work, is to really do training in community clinics, or LGBTQ health clinics tend to always have sort of a mental health focus. And you can learn about some of the key themes that tend to come out when working with diverse communities. And I say diverse broadly, but I do think it is very important to recognize that just because you have a skill that works with a diverse group, you can't use it for all diverse groups. There are certain skills that work when you're working with marginalized communities. So when we think about LGBTQ folks, a lot of the stuff that we talk about really does have to do with shame. A lot of people experience shame about who they are. It is a guilt that is pervasive as a result of sort of certain types of upbringings around, what religion you were raised as, the socio-political environment that tells you to not talk about yourself. We've had that over many years with Don't Ask, Don't Tell, Don't Say Gay bills, things like that are really built to silence someone's narrative. And when you bring it back to, who you're working with as a person, what are the things that make you feel like, a lesser than person, and trying to center that story and bring forth, I think the biggest thing is, as Dr. Joy said earlier, we want to eliminate the negative symptoms you're having, reduce the negative symptoms that you're having, but it is really about healing. It is really about enhancing the positive. And when you think about LGBTQ communities in particular, a lot of that journey is built on getting you to a space where you not only accept yourself as a person for who you are, but you're moving yourself to a space of being proud of who you are. And that's why pride is such an important thing in LGBTQ LGBTQ communities is that you have to be able to say, I am proud of who I am, irrespective of these other forces telling me that I'm not a good person, laws that say that I am not a good person. And so I think building the clinical skill set to be able to help people on that journey is a very specific one that I think relies a lot on being able to work specifically with LGBTQ communities at community health centers. And one of the biggest barriers that we see to training is that there aren't enough of those clinics. And there's a lot of reasons why, but one of the biggest ways that people are getting around them is to try and create more training programs, create more training spaces, welcome doing away rotations. So we have a lot of away students coming and rotating with us from time to time. So trying to be able to create more training opportunities within those spaces to be able to help someone, work with someone from their journey from point A, well, really to who knows what point Z may be. It's a long way to get to that sort of sense of pride, but that's a very unique path that people go on. And so that's one of the biggest things that we try and sort of work when we think about the training piece in particular, is the training around how do you create the environment that allows someone to sit down, but also being able to know what are the important paths that people tend to go on and how to sort of be with them on that path in a way that is clinically, centers someone's narrative and also uses clinical tools to sort of help them get to a space where they really are in a space of healing as opposed to just suffering.
I love that. And I love the focus on centering the folks you are wanting to serve and actually thinking about their experience and how you design that care. To switch gears a bit, but it is something you had mentioned, Dr. Kristen. I could talk days and days about this particular topic, but you had mentioned trauma, and that's the magic button for me. For those who, trauma is a word that has come into the periphery more and more, as well as many other terms from the world of psychology, and it is not often understood, I don't think. And so for those at home who might be new to the concept, and I know this is a hard question, given that you take very deep dives in your work around it, but what is trauma, and how widespread is it in our society?
Yeah, it's almost easier for me to answer the second question than the first question. But perhaps starting with the first is a good one. So I think, as we've talked about, Dr. Joy mentioned this as well, the history of psychiatry really and mental health really matters when we try and create definitions for the words that we use. So trauma is a word that is defined in mental health as it's changed. It's really changed definitions over the years. Briefly, it didn't really have a definition. It was really around sort of like symptoms that people tend to experience when they have been exposed to a traumatic event. But as things, we recognize in our field that like a lot of people have symptoms that tend to coexist with a history of trauma exposure, people really tried to narrow down the definition of trauma. And so in mental health right now, trauma is essentially can be any combination of being exposed to or witnessing actual or threatened death, serious life injury or sexual harm. Those are some of the sort of biggest definitions of it. And so that tends to be what is referred to as capital T trauma. But then there is a whole range of things that falls into sort of this category of lower T trauma. These are things that are, pervasive stress that exists in our world. These are things like emotional abuse, psychological abuse, systemic racism, all of these things that can create a state in our bodies where our bodies just feel tense. They don't feel relaxed. We have thoughts in our head where we're constantly navigating, am I in danger? Is this person going to make fun of me? Can I be safe in this environment, right? And so there's a lot of people who tend to experience those types of symptoms, even if they haven't met this, diagnosis or diagnostic criteria for capital T trauma. And one of the most important things that I think is that people need to know is that the definition of trauma shifts over the years, and you can't really because that definition has changed, it's not helpful to think, is it capital T trauma or lowercase t trauma? You have to think about what's going on in your body. You have to think about what's going on in your mind. And again, going back to your story, and not just a story that thinks about the trauma that you've had in the past. It really has to think about that sort of journey towards healing the body and healing the mind. So if you think about capital T trauma, and this is where things get really complex, capital T trauma, by the time people hit age 18, about 89 to 90% of the population in the United States has had at least one capital T trauma event. When you think about lowercase t trauma and you think about combined with capital T trauma, and you think about everything that adulthood encompasses, the majority of people, at least 50% or so or more, will have had at least one or more traumatic events. And so it's not just about did the event that you experienced meet the definition of trauma. It is much more about how do the things that are going on in your world create symptoms in your body, discomfort in your body, nightmares, panic, tenseness, headaches, stomach aches. If those things are happening for you, it's really about a space of how do we help those heal? How do we help you heal with the things you have, unfair experiences that you've experienced in your past or been exposed to? How do we get you to a space of healing? Defining it as trauma, capital T trauma or lowercase t trauma, is really just a starting point. But that definition, if you're having those symptoms in your body, it's not as important to say, oh, it counts as trauma. It's important to recognize that's what's going on in your body. Your body is feeling the symptoms of trauma. And that's very different, but it's pervasive. It is all around us. And so, feeling what is going on in your body, and knowing sort of the thoughts that are in your mind. Are you thinking about this thing that happened a lot? Is the thinking about it getting in the way of you talking to your friends, doing well at work? If those are things that are happening for you, that is actually a really, that's a good time to sort of say, maybe I do want to seek out mental health help so I can get back to a space where I can do my work well, I can be with my friends well, I can get a good night's sleep, and that's a good start. Or I can learn to cope with the fact that really unfair things do happen in the world, and I can still be a good person. That's a different sort of step. But there's multiple ways we can take it, but it is pervasive. But defining it doesn't necessarily help us reach the solution. Reaching the solution depends a lot on what's going on in the body.
As they say, the body truly does keep the score. Dr. Joy, how has trauma come up in your work, and how has it changed, especially in the past couple of years, as our society seems to be, whether capital T or lowercase t, experiencing trauma en masse?
Yeah, I mean, if we look at the past couple of years, talk about big T and little t traumas happening all at the same time. And I really appreciate what Dr. Kristen mentioned around, because I think sometimes we can get into what I call like these trauma Olympics, right? And so for a lot of people, if it doesn't meet the requirement of big T trauma, then they don't register that as something really big happening in their lives. And so when they come into therapy and they're telling you the story and you react like, oh my gosh, that must have been so difficult, it's the first time that they're really experiencing like, oh, this is not something everybody experiences, or, oh, this was a really big deal, right? And so I think it's really important for us to not get into saying like, oh, I had it bad, but this person had it worse, because it does then negate our own experiences of things that could be either big T or little t traumas in our own lives. And so I think, just over the past couple of years, there have been so many things that are happening. And I'm really, really concerned about what happens on the other side, because I think so many people have just been in survival mode for so long that we have not actually slowed down long enough to really register the impact that this past couple of years has had on us. And so when we think about just the grief of, not only loss of life, but also the loss of normalcy, right? The loss of historical moments that maybe we were looking forward to, like celebrations and vacations. And, all of those things are important. And so I think it's important for us to think about grief not only being as the loss of a loved one, but also the loss of anything that you were anticipating or looking forward to. And again, not saying that anybody's grief is bigger than the other, because there's enough capacity to hold grief related to all kinds of things. And so I think it has been really important for me to talk with clients and to just talk with the general Therapy for Black Girls community about how are you taking care of yourself right now? Like, how are you continuing to just paddle through this? Because I don't necessarily know that thriving is a goal right now, right? Because we are still just trying to kind of make it through to the other side of this. But how are you taking care of yourself, and what kinds of small things can you do on a daily basis, on a regular basis, to kind of just keep swimming?
Oh, yeah. I feel like I'm going through therapy right now. So that's wonderful. So we were just about at time, but I want to end on a note where folks can have some takeaways for things that they can try. Some fairly easy things that they can engage in. Self-care is something that gets a bad reputation in society today. It's one of those words again that have been brought into periphery, but it gets mixed up with like bubble baths and facials, and there seems to be more than that. Dr. Joy, and I'll ask you, Dr. Kristen, as well. But what is how do you do self-care right?
So there is no right or wrong way really to do self-care, but I agree with you, Jayo, that corporations have really sold us on this idea that you need to buy things to participate in self-care, and that's really not what self-care is, right? So bubble baths and facials are great, but you need to do a little bit more digging, probably, especially right now, right? So what do your boundaries look like? Like, how often are you saying no so that you can protect your emotional bandwidth? That's also really important self-care. Who is in your support system? So how are you staying connected to the people who are important to you? And are you allowing people to actually show up for you? That's also a form of self-care. Practicing any faith or spirituality kinds of practices that are important to you, that's also self-care. So all of the things that actually help us to kind of continue to show up for our day-to-day lives, for ourselves and for other people, those are the things that I think are really important when we're talking about self-care.
Took notes. I definitely took notes for a friend. Dr. Kristen, on your end, what is some advice you can give folks to be more intentional about taking care of themselves?
Yeah, no, it's a great question, and I think there are a lot of ways to engage in self-care. I agree with Dr. Joy that self-care is not just about bubble baths, doing things that are kind of like quick aspects of relaxation that are built on what can I buy to help me feel better. Self-care is really about healing the self, and part of that means understanding yourself enough to know, where do I need to heal, right? What are those moments that stress me out during the day, and how do I take care of that? So, I think the first thing to even thinking about self-care is understanding, where does it sit with you? Is it sitting in your body? Do your muscles feel tense? Do you find your chest feeling really tight during the day? Or, is it in your mind? Is your mind racing? Or do you get stuck on a certain thought, and that thought, like I'm not working hard enough, is that kind of thought being the kind of thing that holds you back? So understanding yourself is a really good place to start with. How do I build self-care into my routine? Because if you only do self-care in the way that the media tells you how to do self-care, you're going to be stuck doing yoga, walking your dog, eating every healthy meal, talking to every important person in your life. And all of a sudden you're going to feel exhausted by the end of the day doing all the self-care that you were supposed to do. And that's not the point of self-care. So I think there's a couple of different things that we can kind of walk through. So I think the first one is if you find stress sitting in your body, it's good to be able to sort of recognize when your body is getting tense and having sort of a couple of go-tos around how to sort of decrease that tension in your body. A really good one is just deep breathing. So for deep breathing, the first step of deep breathing, get yourself into a space that is comfortable, relax. And what you want to do is you want to slowly inhale through your nose for 4 seconds. Hold that breath for about 4 seconds, 3 to 4 seconds, and then slowly exhale out of your mouth for about 6 to 8 seconds. And so if you do that kind of cycle, in for 4, hold for 4, out for 6 to 8, and you're doing it in a way where you're sort of, can feel your belly expand, and do that anywhere between, more than 4 times, that sort of cycle more than 4 times. But overall, if you can do it for a period of even a couple minutes, that type of breathing can slow your heart rate down. It can decrease muscle tension in your body as well. And that can be a really good way to sort of reduce intense stress that you're holding in your body in that moment. I think the other thing, if it's not really speaking as much around tension in your body, but you're really focused in more on how is myself being harmed by the thoughts that I'm having. It's another skill that can be used is called opposite action or opposite thought, really. So if you have a thought going through your head that is along the lines of, I'm a bad worker, I'm not a good enough person, people hate me. Think about the opposite of what those things are. I am a hardworking person. I'm a good person. I'm a loved person. I'm a good enough person. I'm a worthy person. Whatever that opposite might be, create a little mantra for yourself that you can say back to yourself. So when a thought pops into your head that says, you're a bad person, you can counter that for whatever reason it might be there. You can kind of counter that with things that are true in your life, where you might be able to say, I'm a good enough person. I am a loved person. I am a worthy person. And being able to just repeat those things slowly in your mind until the thought that is kind of distressing you fades away can be another really good technique to reduce something that can cause tension in your body as well. I think the last thing that I would recommend for self-care in general, and I talked about this a little bit earlier, is that one of the reasons why a lot of us want to go to therapy or is really around the fact that we feel like, we're not good enough people because perhaps we're being judged. And we want to share a non-judgmental space with someone. I think a really great way to start feeling better and more positively about what's going on in the world is to try to not judge other people, try to not judge other people's intentions. That kind of thinking, I hate them, I don't like them, they're not a good person. If we can not only do those reframes for ourselves, but we can do those reframes for the people around us, we'll start to like the people around us more. We'll start to enjoy the spaces that we're in more. And that in turn will feed back to us. So being able to practice non-judgment in your environment can also be a really good way to just start to feel more relaxed in the spaces that we're in. And so those are sort of some of the 3 self-care techniques that I would recommend.
And so with that, and I can clearly talk about this for hours and hours, and I have really, really appreciated your insight. I'm sure our viewers have also, but me personally, I took some notes, and we'll be practicing a few of those things later today. But with that, thank you so much, both of you, Dr. Joy and Dr. Christian, for joining us on this very important conversation.
Thank you for having us.
Thank you all for that important conversation. Next up, we're talking with Wisconsin Senator Tammy Baldwin about policy solutions to address the mental health crisis. Senator Baldwin co-sponsored legislation to create the National Suicide Hotline 988, which is set to launch this July. The 19th's Washington correspondent Amanda Becker is leading today's conversation with Senator Baldwin. Amanda?
Thank you so much for joining us today, Senator Baldwin, to talk about mental health during Mental Health Awareness Month, and for joining us for this very important event.
Well, I'm delighted to. Thank you so much for having me.
So we'll get straight into it to make the most of our time as possible. I wanted to start with the National Suicide Hotline Designation Act that you worked on. And just to give our viewers a reason why we're talking about this now, it actually launches this July. I believe it's July 16th. It was bipartisan legislation that was first introduced in 2019 by Senator Cory Gardner, former Senator Cory Gardner from Colorado, and Senator Baldwin was an original co-sponsor of that legislation. So that's why we wanted her to join us today to talk about it. Tell us a little bit about this. It's launching in July. Why, we already have 911. What were the reasons that you saw, kind of why we needed a different hotline? And for those watching, when it does go live, it will be 988 that you dial on your phone instead of 911.
Well, the need is pressing, frankly. And currently, there are disparate 10-digit telephone numbers that people can call that are suicide prevention lines or crisis lines, mental health crisis lines. And nobody remembers a 10-digit number that you might only need once. Yet once we do the sort of public outreach and education about 988, everyone's going to remember it. And in a crisis, we expect that people will be able to access resources through calling the 988 number. We also have seen in recent years death by suicide increase fairly dramatically. And we also see certain groups having even higher rates, whether that's veterans, LGBTQ youth and adults, farmers and people in rural America. And so having this easy to remember line that is staffed by people who know about mental health challenges, crises, and suicide prevention, and can quickly refer people to the type of services and support they need, this is literally going to save lives.
And how did that bipartisan coalition come together when you first started talking about it? I assume, maybe even in 2018, people were talking about this. It was introduced in 2019. How did that group of senators come together to start working on this legislation to kind of get it over the finish line?
I think each of us had been tackling this topic, but perhaps in more of a piecemeal fashion. For example, I have worked on issues of mental health and suicide prevention for farmers. We have had very tough times in farming in Wisconsin, particularly in the dairy industry, and record numbers of deaths by suicide on farms. And so, in a bipartisan manner, I was working on farmer suicide prevention and crisis intervention programs. Also done a lot of work with the veterans population and recognizing that especially Vietnam era veterans, but now those that were deployed multiple times in Afghanistan and Iraq are dealing with untreated PTSD and need these services. And certainly with the LGBTQ youth, we are seeing a period of time where the bullying and the harassment and hostile laws passing are really isolating and making LGBTQ youth feel without support and without belonging. And so on all of these issues, I had been working sort of individually in these areas. But we came together over recognizing the broader need and that everyone could access from 988. And then professionals could refer people to sensitive, appropriate intervention services. And yet, the time of crisis is when the time of the call occurs. One other quick thing, and you might be thinking of asking me this later, but I'll put it in right now. This number will also take texts. And if you think about how, especially a new generation communicates, that is going to be a really important thing, that somebody might not reach out if they were going to be speaking with an individual, but they might reach out through text. And again, this is definitely going to save lives.
And so again, just for everyone watching, that will be 988, and that launches on July 16th. So what will happen when you call or text 988? Do you have to be the person in crisis? Could you call on behalf of a friend or family member who's in crisis? Will they stay on the line with you? Can they get you kind of emergency services if the situation merits in terms of an ambulance or something like that? How will that kind of work once it launches?
Yeah, so those are great questions. So when you call 988, there will be a trained crisis response counselor or suicide prevention specialist who will be answering the call. There is currently a network of folks, and again, these services do exist, but are accessed right now by local numbers, 10-digit numbers. You have to look them up, et cetera. And so we'll basically have many of the current professionals, but I think we're expecting significantly more calls once the knowledge of this service becomes available. So we are training new. And then we also will have the local partners and local, state, and national partners who will be able to take referrals from the hotline and provide appropriate follow-up. So, for example, there is a mental health focus in the VA, and we know that the background of healthcare providers in the Veterans Administration is very veteran-focused and very understanding of the experience these veterans have had when they were in active duty. And so there'll be an appropriate referral at that point in time. Likewise, if it's an LGBTQ youth or someone working in agriculture, there will be services, hopefully, that are very appropriate to understanding their lives, their struggles. Now, in terms of, there is a difference between 988 and 911. And so I would say that if, this is just my own recommendation, that if you need an ambulance, a fire truck, a police car, if something is unfolding and we need immediate help, I would say 911. But in terms of accessing 988, if somebody is going through a mental health crisis, it doesn't have to be that person who makes the call. You can call on behalf of a friend or a loved one and get advice for you. And if they're right there, maybe you can coax them on the phone. So it will be available to either the person actually going through the crisis or folks who are trying to help that person or intervene in that situation.
Thank you for that, and for that additional information that could be really helpful to people. I wanted to take a step back a little bit and talk about how you came to work on mental health issues. Obviously, you've mentioned your work on behalf of farmers, on behalf of veterans. Mental health is something that touches everyone's life. Suicide is unfortunately something that touches a lot of people's lives. I myself have lost both friends and family members to suicide. What about kind of your personal journey informs how you do this work and why it was important for you to do this work?
Yeah, well, I will say, I've been certainly touched by these issues, just like you, with family and friends. My mother had struggles with chronic mental illness, as well as physical pain that created dependence upon painkillers. And so I am not new to issues of mental health and behavioral health and the struggles that creates. And there were having resources, not just for your loved one, but for you who are trying to keep it together during those times. That's really key.
I want to talk about a piece of legislation you're working on right now. It's called the Into the Light for Maternal Mental Health and Substance Use Disorders Act. That is a mouthful as legislation goes. This is something specifically targeted at pregnant and postpartum people. What specific needs would it fill that other programs are not addressing right now? And let's just talk about that a little bit, because I think that's something that our audience would also be really interested in.
Yeah, well, believe it or not, the most common complication of pregnancy is a mental health condition. And suicide and overdose are the leading causes of death of postpartum women. I will say that I have been reminded by dads that they also can have some mental health challenges that we should be sensitive to upon the birth of a new baby. But everybody, every new parent, every new mom deserves access to mental health care resources, but we are at this point in time leaving too many moms behind, and disproportionately women of color, I might add. So our bipartisan Into the Light legislation will help ensure that regardless of where a new mom lives in America, that they're going to have resources that they need to address their mental health and substance use disorder challenges. And there's numerous ways that we can put that into effect, but part of it is just understanding what sort of a support system a new mom has, and providing outreach and check-ins, not just from the pediatrician and primary care doc, but just making sure that they're getting the support they need to have a healthy start to motherhood.
And what stage is that bill in right now? Have you had hearings about it in committee? Because Senator Baldwin serves on the Health, Education, Labor, and Pensions Committee in the Senate. Do you think it has bipartisan support to move alone? Will it be, as often we see, attached to other pieces of legislation? Kind of where are we at? What stage is that legislation at?
That's great. I almost want to answer all of the above. So it is bipartisan. It has been introduced. But at the same time, the Health, Education, Labor, and Pensions Committee, the HELP Committee, is working on a larger mental health and behavioral health piece of legislation. Some of the aspects of that legislation are going to be looking at some programming that was begun in the last 5 years and is about to sunset if we don't continue it explicitly through legislation. And so that's part of the focus. But we are very much hoping that we can add to that legislation some new areas that are under-resourced right now. And maternal mental health is one of those areas.
What is sunsetting? What programs, and kind of what have we seen kind of about how those programs work and the impacts they're having in various communities?
Yeah, so nothing's sunset yet, but there's several that will what we call sunset or come to an end of their authorization at the end of this fiscal year. And if you think about it, when we several big pieces of legislation that we passed a few years ago. CARA, the Comprehensive Addiction Recovery Act, and the CARES Act, several measures that were really upping our game in, that's a bad way to put it, but upping our activities in the arena of mental health and substance use disorder. A lot of it focused on the opioid epidemic. And we want to make sure that everything that worked effectively and expanded opportunities for people to get treatment and support and reduce harm and death that those programs get reauthorized. And again, we want to look to areas that weren't addressed in those two measures.
Senator, you just mentioned as you take up this legislation that you might fold the Into the Light Act into the ability to address other populations that weren't served by previous legislation. And I would like to talk about child and adolescent mental health and suicide for a minute. I'm sure all of us have seen, or many of us have seen, kind of the devastating series that the New York Times did, as well as the New Yorker recently, on how child and adolescent suicide attempts have skyrocketed over the past couple of years. And they think it's related to the pandemic. They're not quite sure why yet, if it's just screen time or being more isolated from friends and social networks. But is child and adolescent mental health something that you think might be addressed? And our senators already talking about that. I know it's early and they're still trying to figure out the medical reasons, so it's maybe a bit early for policy solutions, but is that something under discussion?
Yeah, and I just want to acknowledge, the heartbreaking death by suicide in Wisconsin by a star Wisconsin athlete, following closely on the heels of another high-profile death by suicide in California of a student athlete. And this is, it's something that breaks our hearts and also reminds us that we still must step up. So I think one of the keys is access to mental health services in schools. So now I'm talking about the younger children. After decades of schools needing to, stretch thin budgets even further, there are not the sort of supports and resources in schools that there used to be, a generation ago. And that includes nurses, that includes social workers that are trained with regard to mental health issues, and mental health workers. We've got to figure out a way to have those services at the nexus where children and adolescents are, and be able to assist parents who need to access these services on behalf of their children to do so. There are some things, there's not much that's positive out of the pandemic, I will say, but the ability to access mental health services through telehealth has been a real breakthrough for many who felt too stigmatized to, perhaps present at an office or because there is still a lot of stigma around mental health. There shouldn't be, but there is. And so that also is a format that I think young people and adolescents feel very comfortable in, because that's often how they communicate with their peers.
Well, thank you so much. We're unfortunately about out of time. I did want to remind everyone, until 988 is active, if you or someone you know is having a mental health crisis, you can call the National Suicide Prevention Lifeline at 1-800-273-8255 or text HOME to 741-741. Thank you so much, Senator, for joining us today to talk about these important issues.
Thank you so much for highlighting them.
Our final conversation centers on grief, something so many are dealing with these days. We are joined by Rebecca Sofer, co-founder of Modern Loss, an organization that connects people dealing with grief to resources and community. She's also author of The Modern Loss Handbook, an interactive guide to moving through grief and building your resilience. Also here today is Leslie Gray Streeter, author of Black Widow, a memoir about loss, love, grief, and healing. Leslie is a journalist, speaker, grief advocate, and lifestyle columnist for the Baltimore Banner. And Torie Bosch joins us to moderate this conversation. Torie is editor of Slate's State of Mind project in partnership with Arizona State University. Torie?
Leslie and Rebecca, thank you both so much for joining us today. And thank you to the audience for joining us. It's really difficult to talk about grief, but also really critically important. And that's why I'm so glad to have with us two women who have done a lot of really important thinking and writing and speaking about how we think about and approach grief. I think it's important to acknowledge that one thing that makes the three of us qualified to talk about grief is that we've all experienced losses that we've written about and thought about at length. And I'd like to maybe ask you each to share a little bit about those losses, since we'll be referring to them, I think, throughout the panel. Leslie, can we start with you?
Sure. It's funny how you think it's like, let's rank them, but no. My husband Scott died almost 7 years ago we were both 44. He was almost 45, unexpectedly of a heart attack. And I think that was the one that, even though my father died a couple of years before that, so that was like the big significant, first big significant loss that wasn't a grandparent, or like you said, someone that you expect to be elderly and die. So both of those things, I felt like there was a weight pushing on my chest, like I had to get them out. And my father, I wrote about in a column, and then they were like, so do you think you'll be ready to write? It's like, yeah, fine. Because, journalists. And I did. And then, so I don't think I would have been able to write the book, honestly, if I had not first done that, because I had already been used to this ripping the Band-Aid off approach. And I write that way about anything I'm writing about: vegan food, Sex in the City, shoes, whatever. But this just happened to be a terrible thing. And I decided if I was going to write about it, I was going to be honest about it. And I was going to, because it wasn't just about me. It was about helping other people with the terrible. So.
Thank you for sharing that. And Rebecca, can you tell us a little bit about the losses you experienced?
Sure. Well, it's very safe to say that I would definitely not be working in my field, the field that found me. I would not have chosen this, but it kind of chose me through life circumstances, like it chooses many people. My mother was killed in a car accident when I was 30 years old. I was working in daily television and very consumed with building up my life and focusing on my career and making friends and dating and everything. And then all of a sudden I had, the rug pulled out from underneath my feet from 1 second to the next, because obviously it was a very unexpected thing. And 4 years after my mom was killed, my father died from a heart attack. So between the ages of 30 and 34, I went from having, two, very intact, very alive parents to neither of them being there for me. For me, it was like this very interesting, when I say interesting, I mean like awful realization that, you're not guaranteed anything in terms of a timeline. And that when you go through a profound loss at say like 30, you're not in a community full of people who like inherently get what you're going through. Everybody else is focused in build mode too. So people don't really, think to stop and, kind of check in on you in a way that really resonates with you, because you also don't know how to ask for people to check in on you, because it's such like an awful thing that we're not good at talking about in this society. And it's like very isolating. And so Modern Loss, which is, my, I guess, community magazine, books, etc., came out of that experience, which was just like the realization that like we do a really poor job of talking about this stuff, and we go out of our way to make it a stigma, and that's really, really silly.
Absolutely. A lot of that resonates with me. My grief credentials, as it were that my father committed suicide when I was 11, and then I lost my mother to suicide when I was 32, so about 6 years ago. And right, our peers haven't been through losing their own parent or spouse, and so they don't know what to do, or we don't know what to do. My brothers and I didn't know how to throw a funeral. That was our first time throwing one. So I think what I really want to talk about today is both some sort of these big ideas about grief, and then kind of how we can help people, how people can help themselves when they're experiencing grief, because there's so much language we just don't have. And helping supply some scripts can be super useful to people. I think grief's been in the news recently, as you two both have written about or are planning to write about. The Diagnostic and Statistics Manual, which is sort of the Bible of psychiatric and psychological diagnoses, recently began including a new diagnosis of something called prolonged grief disorder. Leslie, I know you're planning to write about prolonged grief disorder soon.
It's written, actually. I just hasn't, you know how that goes. I wrote it and then something else happened. So that went first. But yes, it's interesting too, because the day that happened, because of the communities that both of us are in, there was probably a lot else happening in the world that day, but all the pings and stuff I were getting was about this and about, as Rebecca mentioned, the stigma around talking about grief. And I think that the immediate reaction, even though we understand that prolonged grief is a very real, it's very specific, it's about debilitating and sort of mind altering and, just changes that happen. I think they put it to a year for adults, 6 months for kids, that happen after a loss where you can't function, you feel like you should have died too, you don't have a real sense of reality and that sort of thing. And the diagnostic community, many of them believe that and people I spoke to, that it's a great thing because, first of all, people can get help and you can bill your insurance and you can make those things, that kind of treatments real, or even see if it's appropriate to do that before you go into that sort of treatment. But a lot of us felt that people already think you're crazy. People already think that they don't know how to deal with you and you're weird. And are you going to bring the party down if you come? Can we smile around you? Can we mention happy things in our lives? Because, oh my God, here she goes, she's sad. And that we don't want to do anything that would stagnate any progress we've made towards that conversation.
Yeah, so I've done extensive, writing and thinking about this. Just disclaimer, I am not a part of the diagnostic community, nor should I be. I'm a writer. I'm a community organizer and producer, human person in the world, yet I am not a therapist. However, I'm a person who lives with loss every single day, and I shepherd a community of thousands of people around the world who live with loss, and I've learned a heck ton over the last many, many years of what grief looks like and feels like across the long arc. And I think that the danger, what a lot of us are feeling in the non-diagnostic community and also within the therapeutic community, there are a lot of therapists who are absolutely not in favor of this new diagnosis, this prolonged grief disorder, which, by the way, might sound familiar. It used to be known as complicated grief. They keep changing it. When you assign terms like prolonged or complicated or abnormal to things, you're not necessarily helping to erase a stigma, and especially surrounding an experience that is the most natural human experience that you can possibly have after birth, which is experiencing grief. Because as far as I know, no one has cracked that code yet. Everybody is going to die. And so I think that, yes, admittedly, 12 to 15% of people who do experience profound grief, do a profound loss, will require some additional help. They will, as Leslie was saying, they might after 1 year be really struggling to find any joy, not function well, not be able to go to work. And we're talking about really extreme examples, of people who really, have also maybe previously struggled with depression and anxiety. They do need additional assistance. However, we are talking about a 12 to 15% subset of the overall population. So you're really talking about an extreme minority of grievers. And a lot of these things that they deal with are connected to other things that are in the DSM manual, like anxiety, like depression. So I think the feeling is why are you pathologizing grief? Because this isn't really, grief. Grief is an experience, the anxiety, all these other things, they already have how-tos in this book. And so you're not, I think the fear from, people who I've spoken with and also me is that we're not really helping culturally the idea of what grief really is and looks like. And I think that, we like simple things in the United States. We're busy people. We like sound bites. We think, grief. Okay. I think there's a danger of feeling it's been a year, I'm not okay. Maybe I should be on meds. Maybe I should do this. Like something is wrong with me. And that's really not the case for like 85 to 88% of the population. And so our fear is really like how it's being marketed and how it might be perceived. I think that there could be better language use around this, and even maybe like not diagnosing it as grief in general, you know? I think it's very hard because I think that you're really promoting an idea like grief has a timeline, and it just doesn't. Like there are grieving parents who will always feel like they're not fully able to function, you know, that doesn't necessarily mean that they're not functional.
Well, and it's always, and I always say this when I do presentations, it's always good to note the difference between mourning and grieving, right? That grief is the thing that you feel. In some way, you will always feel some sort of grief. There will be a song or a thing or a date or that kind of thing that will make you more in your feelings, as the kids say, than otherwise. That mourning is what we as a society, as Rebecca said, that feels the need to have easy limitations and easy parameters on things. It's the time you sit Shiva, the time between, in the Baptist church that I grew up in, the death and the wake / funeral / chicken extravaganza, you know, where everybody talks and, you know, talks about people and pretends there's no dead person in the casket. So the mourning is the outward thing. And yes, that we feel, unfortunately, in this country, that they should be the same. That once everyone's gone home and you go back to work and the kids go back to school and the flowers have died, that means you're supposed to be better too, whatever better means. And like she said, there's no template for it because we all grieve differently. We all, not only do we mourn differently in different communities, we all grieve differently as individuals. And I had no idea what okay was going to look like when I first lost my husband. I had no idea what that meant. I do know now that 7 years later, I grieve him differently in a way that looks like progress, but there was no telling what that was going to look like. Even the day that I wrote my book, I started my book like a month after he died. I had no idea what was at the end of it. I just started writing because I needed to. And it is so complicated. One of the things that I love about what Rebecca does is that modern loss talks about, they use the word conversation. And that having a conversation about these difficult things involves, what does it feel like to be okay, whatever that means, and to try to put my idea of okay on you, right, and on you and on you. And it's so complicated, like grief. And it's something that we really have to keep talking about. So yeah, I agree that while yes, it's great for the small group of people who are grieving to have something that says, okay, I can get help, it stifles, I'm afraid, the rest of the conversation nobody wanted to have in the first place.
And it doesn't really promote the idea that many people can find an enormous amount of additional help and support and healing through other modalities. And I'm not negating, like there are people who legitimately need help. Absolutely. I'm not negating that, and they deserve insurance coverage and whatnot. I just don't know that it needs to be called complicated grief or prolonged grief disorder. And also, I think there needs to be more of an emphasis on this. Leslie was saying the conversation, like there is so much there's an enormous value in peer-to-peer support, in feeling acknowledged, in feeling like you have an ongoing conversation, ongoing invitation to engage with these topics, you know, like Leslie said, you know, for her, it's a difference between mourning and grieving. For me, it's a difference between grieving and just living with loss. Like that's how I personally call it, because I feel like it's more of a companion, you know, in my life, along with all the other companions that I have. And so I know that I've got this, even when I don't think I have it, somehow, because I know that I can always talk about it somehow. And when you feel like you don't have a channel, you know, a conduit to other people, to this conversation, because you're being told no, like if you're really not feeling well, like you should go to a doctor, you should go to, you know, get a script, get some serious help, you know, you may not think to go to a community, and communities are lifesavers, you know.
I've got to tell you, and you know, Rebecca and I have known each other for a long time, but being able to say to people, both that you know and that you don't know, I feel this thing and having some person you've never met go, I feel this thing too, because what we've done to limit the conversation about grief is that we're all in this box where we think everything we feel is weird. We think everything we feel is wrong. And it's not, once again, helping us get back to the point where we can go to parties and people don't go, oh, the aw face. Everybody.
I know that face.
Oh, the aw face. But if you have conversations where you can just, and I have done this through Modern Loss and through Nora McInerney's group and through Soaring Spirits and through all of these organizations where you just listen to people and go, yep, that sounds familiar. Yep, that sounds familiar. And you just don't feel alone because you don't feel that you're nuts or that you are holding on to something that's abnormal, or that you shouldn't miss that person like you miss them, or whatever it is. Or ultimately, and I say this as a widow, that you're ready to date before people think that you should, and that you can still love this person and still want to, feel the warmth of a human person. It's just all of it. And having conversations with people is what I think keeps that going. It keeps you feeling like you're not about to jump out of a window. Yeah.
Absolutely. One thing that really struck me, Rebecca, in reading a piece you recently wrote for Time Magazine about COVID deaths, we're just about at this horrible milestone of 1 million deaths over the past 2 years from COVID. And you said, a lot of really important things about COVID grief specifically, but I also think about grief generally. There's a phrase you said that people should never use. They should never say, I can't imagine. And can you explain a little bit about why that's one of the worst things you can say in talking to someone who's a loss?
And I know that there are going to be people watching this who are like, I always say I can't imagine. I don't even mean anything by it. I want to stress that I mean almost like as an idea, like as your intention. When I said my thesis was, it's the essay that I wrote for Time Magazine a few weeks ago, and it was surrounding this ghastly milestone of approaching 1 million COVID deaths, official COVID deaths, because frankly, we are most likely at 200,000 more than that in this country because of all the numbers that we've been seeing about like the mortality rate and how much higher it is right now compared to other times. And so there's something called a bereavement multiplier, which suggests that for every person who dies from coronavirus or coronavirus-related illness, there are 9 people who are directly affected by that loss. It could be a caregiver, a partner, a financial partner. It could be so many different things. And so I say that to just like plant the seed of the enormity of the grief that is permeating the world, not to mention like people are still dying from other things. Like by the by, there's so much loss out there right now. And we are living in this like onion of grief related to the loss of our perceived futures, the loss of our present, the addition of unexpected roles in our lives, or the loss of other roles. I mean, there is just so much societal grief. There's been election and political grief. Like we've had a pretty full like grief dance card for the last 2 years. And so when I wrote, I can't imagine, like, this is not something that someone should ever say. I mean it as like, people do tend to say, oh God, like, God, you had a miscarriage. I just can't imagine. And they kind of mean that as like, that's their offering to this person of support. Like, this is my bridge to you, how I'm going to try to connect with you, saying, I can't imagine. And then it's like, then you feel like you've offered something. There are many people who do that because it's not their fault. We don't do a good job of normalizing the conversation. And that's why we're having this event today. But when you say, I can't imagine, what you're doing is kind of othering that person, and you're making them feel that like, I can't imagine, like what you're going through, that's yours. Like, that's not mine. That's not ours. We're not in this together. That's yours. That's your burden to carry. I can't imagine it, and it's okay. Like, yeah, say I can't imagine, but like then be open to hearing what they are going through. I mean, it's okay to put your foot in your mouth. I put my foot in my mouth all the time, every day, and even connected with trying to support somebody who is grieving. You just have to have the best intentions of making it clear that you are very open to hearing their story, and that there's nothing that's going to scare you off about it, that you know that grief isn't contagious, not like a catchable thing. Yeah, it's not COVID. It's something that, will only be bearable to somebody, or can be more bearable and have more of like a flow toward building post-traumatic growth, and figuring out a way to find meaning, create meaning from a loss, if they feel like their burden is being divided up by many and carried by many. And so when I say, I can't imagine, I think people say that and they like don't want to imagine. Why would you want to? It's like highly unpleasant to imagine somebody dying alone in a hospital room from COVID, who had to say goodbye to their family on an iPad. Like, why would you ever want to imagine something like that? And yet millions and millions and millions of people around the world they're imagining that because that's their day-to-day reality. And we are trying to push away the realities of this pandemic right now by getting rid of mask mandates and getting rid of like paid testing, covered testing. And like, it's just, the reality is we're still in a pandemic, and we're also at the tip of the iceberg of a grief pandemic that is going to well outlast the viral pandemic. And we have to do better at sharing our stories and being open to hearing people's stories. And it's not just like in building community and making people feel seen and heard. And like, by the way, that's the most important thing ever. I believe that's what I do at Modern Loss. Like, we provide platforms for people to share their stories in ways that are raw and vulnerable and real, but also only by hearing people's stories are you going to understand the enormity of grief, of the various subtleties of grief, of how it affects you financially and intimately and, house-wise, and like maybe you can't get a car. And there are so many different, and like how hard it is to work and carve your professional path out when you're grieving. Only by sharing our stories and being open to imagining, being open to being truly empathic, like really understanding what it's kind of must feel like to put ourselves in somebody else's shoes, can we understand how important it is to advocate for things like paid bereavement leave, job protections, or better coverage for COVID care. That's the only way we can do this, by imagining. It's not pretty, but the alternative is not helping the next person who's going to go through it.
And somewhat shockingly, we only have about 10 minutes left. So I wanted to talk a bit about sort of some practical ways that we can help people both ask for help and offer help when we lose somebody, or when someone we love loses somebody. Leslie, I think you said in your book this thing that really stuck with me, that when a loved one dies, people want to help so they don't have to think about the fact that somebody recently died. And I thought that was really insightful. And it's also, though, that offering to help is a way we can show love to someone who has experienced a closer loss than maybe we have. So I was wondering if you could talk a little bit about what are some genuinely useful ways to offer help, and maybe some ways that are not super useful to offer help.
To me, the most, and everyone doesn't have this, and I know that I was privileged enough to have a large group of people who helped. And I had people who immediately stepped in and called people, like my sister and my friend Lauren and my mom. They called people they knew. Scott's cousin came and took his phone and called people that whose names he recognized, and called them. And at that point, there was sort of like, we kind of workshopped, we kind of outsourced the stuff, because I needed to figure out, like, I'm the one who had to call the insurance. I'm the one who had to go to the funeral home, but other stuff that needed to be done, like picking people up from the airport, or coordinating who was going to stay at my house, or picking Brooks up from school, from daycare, or who was going to bring the food over, or where different people were what other people's jobs were. My sister came for like my grief bridesmaid, where she was like, here's my list. And she did the thing. So I would say to people, find who the grief bridesmaid is and talk to them. Don't bother the person. My sister always talks about that when I got married, the day before, I handed her my phone and said, this is yours now. If anyone needs directions or whatever, they don't bother me. I'm just trying to get married now. I was just, when Scott died, just trying to live and figure out how my life had completely become screwed up in the last 24 hours and how it was never going to go back. So other people could do the minutia. So if you can organize with the most immediate person who may be the person who told you, and say, hey, do we know if there's a service yet? Do they need help sending stuff to an obituary? Do they need help, whatever the stuff is, picking up grandma from the airport, whatever it is? Because the practical stuff, I know, because you want to get in there and hug the person. You want to get in there, and if they need you, they'll tell you. But I had a friend who would come into my house every day pretending that she just wanted to know what new food had come to the house. And really, she was checking on me, but she didn't want to smother me. So she had a reason to be there. And also there were other friends coming in, and I was like a sad reunion. And she would come and go, oh, so-and-so's here. What chicken do you have? Or what's happening today? And she would eat the food, and then she'd check on me, and then she would leave. And it was a way of being there for me without smothering. And sometimes if I needed to unleash on somebody in that moment, I was fortunate enough to have enough people that weren't going to run. They were going to sit there and listen. The listening, I think, is the most thing. The things that worked for you when you lost someone aren't necessarily going to be the things that work for someone else. So saying, well, I always do this, or I always bring this, or I always call at this particular time, or I always look them in the eye and say, they're happier wherever, it's like, they're an angel on a cloud or whatever.
I've never said that.
Oh,
but people do.
Don't ever. And that's like, when I was reading your story, Rebecca, about, not saying, I can't imagine. Also, they're in a better place. No. There's a reason. It's God's timing. There, like someone said to me, Scott has ended his cycle around the sun. I'm going to punch you in the face. That's not helpful. It's a lot. And so I said, basically just to listen, see where you're needed, see if you're needed, see if your need to help is about you and not about that person. And just because you're fighting with your own grief. And
good one.
And you want to be helpful somehow, see how you can be useful by listening to what people need.
Yeah, I totally agree with everything that Leslie said. And also on a longer term basis, just like, I think that people do. I love what Leslie said about is it about you or is it about that person? Like it's like on Twitter, do we need to weigh in on everything? Is it about us or is it about what someone else is going through? Don't need to weigh in on everything. You don't have to say everything to somebody who's grieving. What the most important thing is to really ask questions and truly listen to the answers. And I love Leslie's idea of going to the grief bridesmaid or groomsman, or as it were. Not everybody has one of those. So, sometimes you really do have to go to the person and say, I think that what people do, and they try to be helpful. This is not, I still believe in generally, which is shocking, the inherent good of society. I don't know how I still believe that, but in May 2022, but here we are. I still believe in it. And I think people love saying if there's ever anything I can do, and then they trail off with an ellipses, but they don't know what you want. They don't know what they want you to do for them. They don't even know what they're eating in an hour. They don't even know if tomorrow is gonna be a tomorrow, And so I think what's really important, if you're trying to provide meaningful support to somebody, is to really continually check in with them, knowing that if they don't want dinner tonight, that doesn't mean they're never going to want to eat dinner. If they don't want you to come take their kids for a day, take them off their hands so they can shower or whatnot, that doesn't mean they're never going to want that. Think about, what can you offer, knowing them that they might benefit from? Is it helping to clean the house, helping to order food, whatever, helping? Are you anal? Do you love organizing papers? Do you love being logistical? Can you help with that? Or are you just somebody who feels like you don't know how else to be helpful other than to offer your presence and your willingness to sit with them in this awful period and not say anything, or make them smile if they need to, or ask them questions about their person? Can you just say, if you're at a loss for what to offer, I don't know what to say, I don't know what to offer, I wish I knew the perfect thing, but I'm here, I care about you, and I'm going to keep saying this to you because sometimes you're going to know what you want, sometimes you don't. Tonight, can I come over? Can we just sit? Can I watch a movie with you? The worst they could say is no. but they're never going to be insulted that you offered. And I think moving forward, it's really important to remember that grief does not last like the shloshim, in Judaism, like the first 30 days, and doesn't last that first like year, 365 days, and you move on to year 2, and then everything is automatically lighter again. Like there's no such thing as like a linear grief, like a grieving model that like doesn't, go back and forth and back again. That's just like the way grief is, like a big pot of spaghetti, that just like never ends, that someone forgot to put olive oil on. So it's like all sticky and disgusting. And so I think it's really important to, if you do know somebody and you marginally care about them, like even if they're a good acquaintance, can you remember the day that person had, their person died? Can you put it in your Google Calendar? Can you find out when the person's birthday is? Or like, did they lose a mom? Did they have a miscarriage or a stillbirth? Can you mark Mother's Day and say, okay, text Sarah, like it really doesn't take that much effort to actually put little things in place for you to provide meaningful support to somebody. These are time. I mean, I could talk till the cows come home, but you're running out of time. But like, I just want to say that people get overwhelmed and they feel like they need to do everything for that person. And all you need to do is something, and what you don't need to do is assure them that they're in a better place.
And so the last thing I'm afraid we have to sign off is I wanted you to each give one really, really brief piece of advice of how to ask for help when you're grieving somebody.
For me, it was when I was widowed, I knew people, unfortunately, in my life who had been widowed. Both my mom, one of my best friend's husbands, his first wife had died of complications of diabetes. And so and he's my age. And I would call and say, how do you do this? Or basically saying, do you ever want to punch people in the face? Or whatever it is, whatever human emotion I was having that didn't feel like people outside of that experience were going to understand, that I could go to them and say, I just need you to talk. I just need you to talk to me or listen to me. And that was the first, just the humans, even before I went to therapy or whatever, just the humans in my life who I knew weren't going to judge me or think I was weird for having these emotions. So just saying, can I ask you a question with someone that you trust was really important.
Rebecca?
Yeah, I mean, I struggled with asking for help for a really long time. So I think that it's like understandable if you don't know how to ask for help, because we don't, again, do a good job of telling people that they should ask for help. But I think that, it's really important to remember that like the word empower, I think is like a silly word. Like you already have power inside you. You don't have to empower yourself. You have power. You may not know what you need tomorrow, but you might know what you need at this very moment, especially in those early days of grief. And think about like what needs to be nourished. Like, is it something practical or tactical? Like, who do you know in your life who can do that for you? Do you feel like so incredibly awful that you literally need to just like be in denial and watch like an awful episode of something or whatever, and just know that you're not the only person in the room? Who in your life could you call to come over and do that with you? Or do you need a distraction, someone to make you laugh? I think that some of it is just getting really like in the weeds and thinking like, what do you need at this very moment, and not overwhelming yourself with like, what do I need like next year? Like I think we've all been proven over the last 2 years that, we have no idea what's around the corner, on any given day. And all you can do is anchor yourself in the moment and like figure out what you need in this moment. That is the way to do it. It's micro, it's baby steps. And that is the way to move through any sort of adverse situation. This thing is a marathon. It's not a sprint.
Thank you both so much. This has been really useful, hopefully enlightening, and grateful to have folks like you thinking about grief in this really difficult moment in the US. So thank you. And thank you too for some moments of laughter. I think both of your writing brings out some surprising moments of humor when we're at our saddest, and it's super important. So thank you, everybody.
I'd like to extend a big thank you to all of our speakers and participants, and to all of you for joining us today. Thanks again to our sponsor, Pharma, for making this event possible, and a reminder that this year's The 19th Represents Summit is right around the corner. We will be gathering from June 15th to 17th here online and in Washington, D.C. to explore 50 years of Title IX. Visit 19thnews.org/summit for more details. Finally, thanks to the thousands of 19th News members who support our nonprofit newsroom. Your donations make conversations like today's possible. If you're not a 19th member yet, we'd love to have you. Join us at 19thnews.org/membership. We look forward to welcoming you to the 19th family, and we'll see you in June.